Hey, I'm Jeff Gadsden.
I'm Amit Pawa, and we'd love to share with you our RE UK 23 pro-con debate looking at the subject of nerve stimulators and regional anesthesia.
I'll be arguing that trainees should be taught how to use nerve stimulation, and Amit will be taking the con side.
We hope you enjoy what we put together for you, and don't forget to follow our podcast, Block It Like It's Hot.
Okay, hi, I'm Jeff Gadsden, and in the next 15 minutes or so, I hope to convince you that yes, there is a role to nerve stimulation, and absolutely we should be teaching this to our trainees. So when I finished training in like 2000 and something, there was this weird dichotomy, and people were saying, well, now that we have ultrasound, we don't need to use nerve stimulation, as if the two were mutually incompatible, and it was this either or situation. It was a really odd way to frame it. And I still hear this from some of our trainees now and again. Well, we have the imaging now. Why would I need to use any of your old dinosaur techniques, Jeff? And I hope to convince you that yes, there is still a role for this. So I'm going to say I have a friend, and I'm not going to name names, but she actually rips the wire off the needle, which I think is a super aggressive move and unnecessary. Like, how much does this little wire actually offend you that you have to remove it from the needle? Okay, so how does this help? I'm going to propose 4 different ways that nerve stimulation can help you in your clinical practice, and therefore that's why we need to teach trainees how to use this. Number 1, it can be used as a means to identify when the needle tip is too close to the nerve, and I'll get into more detail on that in a second. It can be used to prevent direct needle trauma or nerve kebabs when the nerve lies directly in the path of the needle. It's a way to help us when ultrasound can't help us, and we do have blocks now and again where the nerve just can't be seen with 100% reliability. And finally, I'll propose to you that it can be used to help us find the correct intermuscular fascial plane now and again. Right, so in terms of detecting needle-nerve contact, yes, I will admit it's not perfect. The sensitivity of nerve stimulation is not 100%. You can be, in other words, inside the nerve, have the current on, and maybe not get an evoked motor response. But here's the thing, if you are getting an evoked motor response at 0.2 milliamps or less, you're in the nerve. Every single bit of human and animal data that we have suggests that this relationship is robust. So yeah, while you can get a variety of minimal current threshold responses when your needle tip is outside or inside the nerve, here we see the minimum current intensity needed to get a twitch varies immensely no matter where your tip is, the only time you'll get it at 0.2 or less is when you're inside the nerve. And that's how we use it now. We don't use nerve stimulation to find nerves, we have ultrasound for that, but this is a way to help stay out of nerves. And so nerve stimulation is insensitive, but is apparently very specific. If you're getting a twitch at a very low current intensity, you're either kissing that nerve or you're inside it. Not good. And some people have suggested that we use nerve stimulation as an adjunct in this so-called triple monitoring, the idea of using ultrasound, injection pressure monitoring, and nerve stimulation all together to put us in the safest possible space. Because, like I said, there are times I'm not confident with the image, and I'd like to have this as a backup to keep me safe. About once every couple of weeks, a trainee will be advancing the needle across the screen, and the needle is coming up into the plane and out of the plane and into the plane and out of the plane, and I'm not sure 100% of the time where the tip is. So I'll turn the current on, set it at the foot of the bed, and forget about it. And I'm looking to not get a twitch. So if I do feel a twitch, we're like, whoa, 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 everyone stop. Let's pull the needle back and figure out where we are. Now, I cannot offer you tons of randomized controlled trials saying that nerve stimulation saves nerves, but what I can offer you is this story. Jack was a patient who had a popliteal nerve block and has a lifelong disability because that practitioner put the needle inside the nerve and caused a permanent injury, and Jack will never work again, and he'll never enjoy his life again because he is in constant pain. And so when I think about the threshold for me to use a technology or a monitor, there are some things that I think, yeah, I do want to see a randomized controlled trial to prove that it's effective. But when the outcome is so potentially catastrophic, I don't need a lot of convincing. I'll say, you know what? I'm going to use it, and probably most of the time it's unnecessary. But that one time in 100, like Jack C, I'm going to be glad I did. And I get pushback sometimes saying, ugh, Jeff, what a hassle. I mean, putting the nerve stimulator on, pulling in an extra bit of equipment. I want to show you. And for those of you who have never used a nerve stimulator before, this is an instructional video. So here we go. We connect the wire, we take the sticker, and we put it on the patient. Oh, and I know there was a lot going on there, so I'm going to slow that down. Here's the sticker. She takes the backing off the sticker, and she puts it on the patient. You know, it's not that hard. Now, a way to avoid skewering nerves. If you're like me, you're a fan of the Raptor block. It's a great solution to some things, but there's a problem. So the trajectory comes underneath the clavicle, like this. And some have suggested, ooh, you know what? That's a little bit close to the suprascapular nerve for my comfort because it may be hidden in the clavicle shadow. And there's been a publication on this using cadavers, and sure enough, the nerve is somewhat close to that trajectory. But we have a solution. Stimulation. So as I'm bringing the needle across underneath the clavicle like this, I rest my hand on the supraspinatus fossa, and if the needle were to get quite close to the nerve, we'd feel a twitch of that supraspinatus muscle. We don't actually get this very often. It's quite rare. The Raptor's a pretty safe block, but that's a hedge against the criticism of that particular block. And here's another one that's near and dear to my heart because we do this every single day where I work. Of course, we know that the adductor canal block is not just about the saphenous nerve. It's the nerve to vastus medialis that helps explain why this block actually works better than it ought to. And the problem is we can see the saphenous nerve pretty well on ultrasound, but we can't see the nerve to vastus medialis all that well. And maybe it's this little smudge here, I'm not really sure. Here's another part of the problem. There's a vastoadductor membrane that separates these two nerves. So if you're just going to put the local next to the artery, which is how I was taught to do this block, it's not going to spread well to the nerve to vastus medialis. So you have to separately block these two nerves, in my opinion. Here's an example of a needle coming across, and we've already started to expand this compartment with some saline, and you can see the nerve to vastus kind of being shelled out with the contrast from the fluid. And then we click, move forward, and pass through the vastoadductor membrane and get the saphenous nerve separately. And so there are two different nerves in two different compartments. But if I can't see it, how do I both block it and protect it? And of course, the answer I'm going to tell you is nerve stimulation. So this is 100% how we do this every single day. We bring the needle across in that intermuscular plane. I have my hand on the vastus medialis muscle by the knee, and the trainees advancing, and then all of a sudden, we get a twitch, and many times, friends, it's not where I think it is. And it's like, whoa, okay, I guess the NVM nerve is a little further out lateral than we thought. So we propose that this is something that we do both for efficacy, so we get to block that nerve, but also to avoid harming it. Because I've now heard of 4 different cases of patients that have had uneventful adductor canal blocks, and in the weeks to months after have had isolated vastus medialis atrophy. Now, I'm not sure of the mechanism. It could be a couple of things, but I suspect that because the needle trajectory takes you right past that nerve, some of the time we probably contact it and or put it at risk for injury. Why am I so sure? Well, we did a cadaver study recently that looked at this. We put needles in old school style, right? Look for the artery, advance a needle to the artery, and then put wires through the needles and take the needles out. When we opened the cadavers up, over 50% of the time, the wires were either touching the nerve to vastus medialis or in fact passing right through the nerve. So again, nerve stimulation can help identify those nerves before you cause harm. And then there's this. So, subgluteal sciatic block, I love it. We use it a lot for amputations, but once in a while we get a picture like this and I'm like, where I can sort of see the bones, but I can't see the nerve. Look, I work in the biscuit belt in the US and there are a lot of robust patients, so identifying a crisp, clear nerve can be challenging, and nerve stimulation is a beautiful functional adjunct to say, oh yeah, that is a nerve, not just some random smudge on my screen. And then finally, stimulation helps to find the correct interfascial plane. And this is a kind of a different way to use a nerve stimulator device. Take the anterior QL block, for example. I want to land that needle right here between the QL and the psoas major, right in that plane. The problem is, if you put the local in the psoas muscle itself, you're going to end up with a lumbar plexus block. And we did this a number of times. You get great abdominal coverage. Oh, and guess what? You can't move your left leg because we've taken out your quads with a lumbar plexus block. So what we do now is we turn up the nerve stimulator to like 2 or 3 milliamps. Like that's a huge current. And as the needle comes across the screen, you'll see the muscles contracting directly like dink, dink, dink. So here we go. Here's a needle in the erector spinae muscle now, and you can see it contracting. Dink, dink. And then we pass into the QL, and there's a cute little QL going dink, dink, dink. And then as you pass through the QL and into the correct plane, you lose the twitch. No twitch now. Inject, beautiful, right in the correct spot every single time. Now sometimes you'll see the psoas muscle twitch and then you just have to pull back until it disappears. Since we started doing this, we've not had a single, knock on wood, case of quads weakness after our QL blocks, and we do a lot of them. So this is a cool use of the nerve stimulator, not so much to stimulate nerves, but the muscles themselves. So, 4 different ways that this can help you. And, I kind of think of having this conversation about nerve stimulation versus ultrasound is kind of like airbags versus seatbelts. And I imagine if we all took a time machine back to the 1980s when airbags were introduced, it'd be a conversation somewhat like this.
Hey man, what's up? Hey, how great are these airbags? Hey, yeah, airbags are rad. I mean, between that and seatbelts, I feel really safe. Wait, you're still using seatbelts? Yeah, why wouldn't I? Ugh, they take too much time. You have to connect the thing. Dude, it's right there beside you. It's just a click. Also, they don't work the same way. They protect you in different ways. Oh my God, you're such a wuss. I bet you wear a helmet when you ski too.
I feel like I have this conversation once a month with somebody. Oh, you're so lame using a nerve stimulator. Anyway, the data is out there on both seatbelts and airbags, and they work in a complementary manner because they don't work in the same way. And that's true for ultrasound and nerve stimulation. They give us different information and protect the patient in different ways. So I reject this idea that it's a competition between these two things. It's a love affair, and we should be celebrating how well these two technologies work together. And speaking of working well together, there's this. So if you haven't listened to this podcast, it features one amazing, handsome, charming co-host and also me. Now, you can imagine that in creating an episode, there's a lot of audio that ends up on the cutting room floor, and I want to share with you just a little bit to help round out my argument. Now, this is from Amit, my co-host and opponent here.
So, I have a confession to make.
I'm scared to ask.
I actually love nerve stimulation, more than Disney.
Oh my God.
And I would never do a block without it.
It's so good to hear.
But don't tell anyone, okay?
Wow.
Can we rename the podcast Stim It Like It's Hot?
Well, there you have it. Hard to argue with the man himself. Thank you very much for your time, and I hope I've convinced you that our trainees should be taught how to use this useful technology. Thank you.
Okay, it's time to be real. As you've seen already, this will be a fun debate, and Dr. Gadsden will stop at nothing to secure a win. But the whole purpose of doing these fun debates is that we want to deliver effective regional anaesthesia education, so that ultimately it's the patient that will be the winner. So let's get stuck into it. Should trainees still learn to use nerve stimulators? And I'm discussing the con side of this pro-con debate, but the way that I interpreted this question was, should trainees still learn to use nerve stimulators to locate nerves for every block? And in my opinion, the answer is clearly no. So I do have some disclosures. None of these disclosures will impact on my ability to deliver this talk, except for one. I leave regional anaesthesia after delivering this talk, and I leave the board of regional anaesthesia UK. And in fact, this photograph was a live photograph that was taken from my final board meeting. So you know how much this means to me. So when you're considering who to vote for, please bear that in mind. Okay, so let's be serious. I'm not going to use any cheeky subliminal messages to tell you who to vote for. So let's get stuck into it. Jeff and I are good buddies, and we've known each other for a while, and we do a podcast together, but the topic of nerve stimulators may be the one thing that truly divides us. I want to remind you what the goal of regional anaesthesia is. It is, of course, to put the right dose of the right drug in the right place. And let's revise that cross-sectional neuroanatomy. Here's a cross-section of a peripheral nerve. There's the epineurium. There's a fascicle, there's a perineurium, and there is the endoneurium, and that is a nerve fibre. Now clearly, we want to inject local anaesthetic in the right place, so perineural injections are of course correct. Intraneural injections are probably bad to do, but we definitely do not want to do intravesicular injections. So now that we've reminded ourselves of where to go and where not to go, let's look at that timeline of peripheral regional anaesthesia. So back in the day when Dr. Gadsden started practicing regional anaesthesia, people were just using landmarks, and then they moved on to paresthesia, nerve stimulation, and ultimately ultrasound. Now one would hope that as you've gone from more primitive, let's say, techniques to the more advanced techniques, that there would be an improvement in the safety of regional anaesthesia. Sadly, the long-term nerve injury risk is unchanged at about 2 to 4 per 10,000. So now that we have that information, the thing that I really need to decide is, do we need both ultrasound and nerve stimulation or peripheral nerve stimulation to perform regional anaesthesia? As you can see here from this list of supposed benefits, compared to peripheral nerve stimulation, ultrasound had a whole host of potential advantages. Now, I got all of these from a really useful article that was written by somebody who you might recognize. And in fact, what Dr. Gadsden said in this same article was using nerve stimulation as a supplement to ultrasound-guided techniques does not appear to add value to success rates. So that should have been it. That should be my mic drop moment. But you know what? I'm not going to make it that easy for myself. Let's look at things in a bit more detail. The premise behind using peripheral nerve stimulation is to aid us with nerve identification and nerve injury prevention. So you know the deal here. We'll get electricity connected to a needle and we'll approach a nerve. And as that electrical signal gets closer to a nerve, we hit the right spot, we'll get motor twitches. We then reduce the current to that threshold level and use that as a guide for how close we are to the nerve. But the question is this always reliable? Now, you've heard Dr. Gadsden talking about using 0.2 milliamps, but I know for a fact that most people, when they're using these techniques, have the twitcher on at 0.5 milliamps as a threshold value. Now, armed with that knowledge, let's have a look at some papers. So in this first study, which is a pig study, they took 20 pigs and they exposed both of their sciatic nerves. Now, in 30% of cases, there were no twitches when the needle was seen to be 0.1 centimetre from the nerve, which is worrying. In 5% of cases, when the needle was on the nerve, there were still no twitches. Now, when the needle was inside the nerve, in 12.5% of these cases, they only got twitches at greater than 0.8 milliamps. And in some of these intraneural needles, there were no twitches even when the current was turned up to 1.7 milliamps. This is making me nervous. Now, this next study, carried out by some names that you may recognize, was performed on 5 pigs, this time looking at bilateral brachial plexus blocks. The needle was inserted intraneurally into the brachial plexus and they aimed to determine the minimum threshold current, and they also then visualize under ultrasound the injection taking place. Now, what they found is in 45% of these cases they required a threshold current of greater than 0.5 milliamps, even though the needle was inserted intraneurally, and ultrasound was good enough to be able to detect just 1 mil of this intraneural injection. Now, I know what you're thinking. He's done 2 pig stories already. Is he going to do the 3 little pigs? I'm not going to do the 3 little pigs, but now I'm going to talk about a study on 53 humans. So in this paper, they performed an axillary brachial plexus block using paresthesia as an endpoint. And once they'd elicited paresthesia, the idea was to determine what the minimum threshold current was in order to get a twitch. Now, when these needles had elicited paresthesia, in only 23% of cases did they get a twitch at greater than 0.5 milliamps. So they got paresthesia, the needle was touching the nerve, but in only 23% of cases did they get a twitch at greater than 0.5 milliamps. So what we've determined here is that nerve contact, assumed by paresthesia, was associated with an absence of twitch at 0.5 milliamps. This is definitely making me wonder what on earth is going on here, but I know what you're saying. Paresthesia is old school. So in this study, in 103 humans, they did an ultrasound-guided axillary brachial plexus block, but they aimed to get the needle in contact with the nerves. And what they found fascinating was that only 38% did patients report paresthesia. And when they had that needle contact, in 25% of cases, they required currents of up to 1 milliamp. So what have we learnt here? Nerve contact does not always generate paresthesia, and in cases when you do have nerve contact, you may get no twitch at all at 0.5 milliamps. This is worrying. How about this study? In this study, they performed their popliteal sciatic nerve blocks using a threshold current of 0.5 milliamps as their endpoint. They measured the cross-section of the nerve before and after injection, and what was fascinating was in 66% of cases when they used threshold current of 0.5 milliamps as an endpoint, there was an intraneural injection. 66% of cases had intraneural injections using 0.5 milliamps. So clearly in these 42 patients, peripheral nerve stimulation did not prevent intraneural injection. So I think hopefully we've demonstrated that we can send peripheral nerve stimulation alone packing as 0.5 milliamps alone is unreliable. Well, what about the love affair between peripheral nerve stimulation and ultrasound? How about using them both together? So this is a great study performed by somebody that you might recognize. What do they do in this study? Well, they perform popliteal sciatic nerve blocks on humans using ultrasound and peripheral nerve stimulation, and they had their twitches set between 0.2 to 0.5 milliamps, and they carried on advancing towards the nerve until they got twitches at that threshold, and if they didn't get twitches at that threshold, they then proceeded to enter the nerve. They used injection pressure monitoring, aiming to keep their pressure below 20 pounds per square inch. And what they determined was, in 83% of cases, they only got twitches when the needle was visualized to be intraneural. And in 17% of cases, there were no twitches when the needle was intraneural. So hold on a minute, peripheral nerve stimulation did not prevent intraneural injection as visualized on ultrasound. So I think we can say that if you want to prevent kebabbing nerves, peripheral nerve stimulation does not prevent intraneural injection. So what about efficiency? This is something people often worry about. If you're using multiple pieces of kit, does it slow things down? Well, in these two studies here looking at infraclavicular blocks, they were able to determine that when they used ultrasound and ultrasound plus peripheral nerve stimulation for infraclavicular blocks, the procedure time was much shorter when using ultrasound alone, and actually the success rate was as good, if not higher, when using ultrasound alone. So why would you want to combine the two? This was another study now looking at femoral nerve block, and what they determined when they took ultrasound versus ultrasound plus peripheral nerve stimulation for femoral block was that actually the procedure time was much shorter and there were less needle passes when we used ultrasound alone. So that's not really giving me any real reason to use peripheral nerve stimulation. Now, we always talk about safety. So does dual guidance using peripheral nerve stimulation and ultrasound prevent harm? Well, I'm going to show you a very sad case here, actually. This case, they use, well, I think this is pretty heavy sedation, but apparently the patient was responsive. They use 8 milligrams of midazolam and 50 micrograms of fentanyl for sedation, and they performed a supraclavicular brachial plexus block using a 22 gauge 5 centimeter needle. They used an ultrasound and peripheral nerve stimulation technique in plane and aimed to stop when they got twitches at 0.4 milliamps. Post-procedure, however, the patient developed pain in their posterior arm and allodynia, and they got confirmed brachial plexopathy, and they had a permanent wrist drop for 8 months. So this is clearly not an ideal outcome, and it showed that actually using ultrasound and peripheral nerve stimulation did not prevent harm when they were both used together. So the real question is, do we need to get that close? Even though we can see how close we are with ultrasound, maybe we can achieve success by being a little bit further back. The best example I've got of this is this paper, which definitely changed my practice and introduced that whole concept of intraplexus injections for interscaling block versus periplexus injection. Now, when I first started performing interscaling brachial plexus blocks under ultrasound, this is what I used to do. Go between C5 and C6, come above, go above C5, then go back again and inject between C5 and C6. It was very aggressive video gaming type of needling. But actually, all we need to do is to do a periplexus injection and inject local anesthetic on one side. And when you do that with ultrasound alone, you will determine that periplexus injections are as good as intraplexus injections. So let's not be that aggressive. There was another paper here that took that whole concept a little bit further. They started off doing a periplexus injection, and every time they got a successful block, for the subsequent block, they brought the needle back a bit and then performed the block. And again, if that block was successful on the next patient, they brought the needle back even further. And what they determined was using ultrasound alone, the maximum effective distance for a 50% success rate was actually 8.5 millimeters away from the nerves in the interscaling groove. So in 50% of cases, you can get a successful block if your needle was actually within the middle scaling muscle. But look, even for an MED of 95, you could be 1.6 millimeters away from the nerves. So we don't need to be that close. So all we need to do is to deliver the right block in the right way. What else am I talking about? Well, I used to perform lots of supraclavicular brachial plexus blocks, and when I used to do them, I used to do an intraplexus or an intracluster injection. So in this study on cadavers, they did targeted intracluster supraclavicular injections. So this is literally putting the needle inside that supraclavicular brachial plexus and injecting over there. And when they did that, they found that 32% of cases of there was injection outside the epineurium. So that's good, but more worryingly, 44% of cases of those cadavers, there was a subepineurial injection, but it was still outside the perineurium. But in 24% of cases, that targeted intracluster injection was associated with subperineural injection. So either don't do the block or don't inject intracluster. Peripheral nerve stimulation will not help you in these cases. Now, taking that whole concept on a little bit further, as a wise Jedi once said,
All blocks are fascial plane blocks.
Now, what did Jeff mean by that? Well, actually, we don't need to approach a nerve directly and inject right over there. What we can do is to hydrodissect within the fascia towards getting towards the nerve. That's a safe way of performing the block, and you can do that with ultrasound alone. But also, you can tangentially approach the nerve. So these are all things that we can do when using ultrasound performing our blocks to minimize the risk of harm. And there's a lot of discussion about some of these concepts that comes up in this paper over here. So what have we shown so far? We've shown that 0.5 milliamps does not prevent intraneural needling. We've shown that peripheral nerve stimulation when used with ultrasound takes longer with no obvious benefit. Touching a nerve does not always generate a twitch, and the ultrasound can detect intraneural injections. So that's great, we can see that. We also know that we don't need to get that close to the nerves, and we can avoid performing high-risk blocks or high-risk practices. So in summary, we don't need peripheral nerve stimulation for regional anesthesia. So what do? Now I'm going to give you a bit of a heads up here. This comes with a trigger warning, Jeff, so this is what I do. I take the needle, I pull off the wire, look how clean and pristine that is. So now I'm going to challenge you. I'm going to show you a few videos here, and I want you to tell me whether you think you need nerve stimulation to work out whether this practice is safe or not, or whether the injections are intraneural. Let's look at these videos over here. You can see the needle approaching some areas in the interscalene region. In cadavers, don't worry. Oh my God, look at this. Do you need nerve stimulation to tell if that's bad practice? How about this tibial nerve here? We're getting the needle, which is going to pop through. Oh my goodness me. Can you see that? Does nerve stimulation add anything there? I would say no. Ultrasound can tell you that that needle has gone intraneurally. So I'm going to take you one step further, and this is coming with a controversial warning. Don't try this at home. But there is one person whose name was Beagle Ison, and actually he suggested that actually intraneural injections maybe weren't even that bad. He took 26 patients and he intentionally injected intraneurally in the axillary brachial plexus block. These patients had no neurological sequelae for up to 6 months. So whilst I'm not recommending it, I'm just saying that maybe it wouldn't be the end of the world if it happened, but definitely don't try this at home. So are there any exceptions? Well, clearly we've heard Dr. Gadsden talk about some of these. Maybe there are, if their nerves are deep or difficult to visualize, and I have had the occasional block where it's been difficult to do with ultrasound alone. Maybe if there are other nerves in the needle path, if there's challenging anatomy, and as we've heard already, maybe we can use it to identify nerve to vastus medialis. But the question is, do we need nerve stimulation for every single block? And I would argue no. So in summary, I think we need to focus on teaching Plan A blocks with ultrasound. We know now that nerve stimulation reduces efficiency, and it doesn't improve accuracy, and it certainly doesn't prevent intraneural blocks, but there may be limited utility for nerve stimulation in certain cases. Ultrasound only for blocks? Yes, we should just block it, because folks who use nerve stimulation for regional anesthesia just accumulate more equipment. They elicit pain when they use them with patients with fractures, they fiddle with the needle a bit more, and they falsely reassure themselves. We don't need nerve stimulators for regional anesthesia because it avoids conflicting information. Most of us don't use them anyway, and is there any evidence to change practice? Thankfully, ultrasound is safe enough, so keep it simple. So I take you back to our original topic. Should trainees still learn to use nerve stimulators to locate nerves for every block? The answer clearly is no. vote against the motion. And in the meantime, do make sure you check out our podcast, Block It Like It's Hot.